1 in 4 adults is carrying fat inside their liver cells right now, not around the liver, inside it. And the standard blood panel their doctor ordered last year almost certainly didn't catch it. The liver enzymes most physicians check can read as completely normal, while fat infiltration is already underway and early inflammation has already begun. The organ is resilient enough to absorb years of dysfunction in total silence. That silence has a metabolic address. In 2023, the medical community formally reclassified this condition because the liver, it turns out, is not where the problem starts. After 50, the biological environment shifts in ways that make fat accumulation faster and clearance harder. Hormonal changes, muscle loss, inflammatory load, in a pattern that dietary advice alone was never designed to address. Most people who receive this diagnosis are told to eat less fat, cut calories, and move more. A significant number of them do exactly that, with genuine discipline, and see limited results. The reason is not effort. It is that the advice is solving for the wrong variable. The fat building inside the liver is not coming primarily from dietary fat. The visceral fat driving the worst of the metabolic damage is not the fat you can see or grab. And there is a specific hormonal mechanism running quietly in the background, shaped by sleep and stress as much as by food, that keeps the body locked in a fat storage state regardless of how carefully someone is eating. What is actually happening inside the liver at the cellular level? And why does the standard approach keep missing the source? What does the metabolic environment producing liver fat do to the heart, the kidneys, and the brain in ways that won't announce themselves for years? And what does genuine reversal actually look like? And how would you know if it's happening? Everything you need to know, starting now. And if this is the kind of conversation you want more of, subscribe and stay close. There's no warning signal your body is designed to send up, not once. And that's exactly the problem. Because by the time most people find out something is wrong with the liver, the process has already been underway for years, sometimes quietly for an entire decade, without a single symptom they could point to, or a single morning they woke up feeling different. The condition has a new name now. What used to be called non-alcoholic fatty liver disease, NAFLD, was officially reclassified in 2023 as MASLD, metabolic dysfunction-associated steatotic liver disease. The name is a mouthful, but the reason it changed matters. This is not a liver disease caused by drinking. It's a liver disease caused by a metabolic system that has been pushed past its limits for too long, by excess calories, by chronically elevated blood sugar, by the slow hormonal shifts that come with age, by years of visceral fat quietly building around and inside organs. The reclassification wasn't just semantic. It was the medical community acknowledging formally that this is a systemic problem wearing a liver label. What MASLD means, stripped of the medical language, is this: fat is accumulating inside liver cells where it doesn't belong. Not around the liver, inside it. And unlike the fat you can pinch at your waist, this fat is completely invisible. There is no pain, no swelling you would notice in the mirror, no warning signal your body is designed to send up. The American Association for the Study of Liver Diseases estimates that roughly 1 in 4 adults worldwide has some degree of hepatic steatosis, the clinical term for fat infiltration of liver tissue. In people over 50, that number is meaningfully higher, and the overwhelming majority of them have no idea. Here's what makes this particularly deceptive. The liver is one of the most resilient organs in the human body. It can absorb a remarkable amount of dysfunction before any of it appears in a standard blood panel. The liver enzymes that doctors typically check, ALT and AST, can read as completely normal even when significant fat accumulation is already present and the early stages of inflammation have already begun. That's not a reassuring fact about the liver's durability. It's a warning about how long a problem can go unaddressed because nothing is visibly wrong yet. The reason this conversation is especially urgent after 50 is that the metabolic environment changes in ways that make fat accumulation easier and clearance harder. Hormonal shifts, declining estrogen in women, declining testosterone in men, alter how the body partitions energy. Muscle mass begins to decline, reducing the body's capacity to pull glucose out of the bloodstream efficiently. The liver, which has always been the central processor of everything you eat, is now operating in a more hostile metabolic environment. It doesn't get a pass from aging, and understanding what is actually happening inside it is the only starting point that leads anywhere real. What is accumulating isn't random, and it isn't only happening in the liver. The fat doing the most damage is the fat that doesn't show up anywhere. Not on the scale, not in the mirror, not on any panel your doctor routinely orders. Most people think of body fat as one thing. You have it or you don't. You have more of it or less of it. And the common assumption is that the fat you can see, the soft layer under the skin at your belly, your hips, your arms, is the fat that's causing the problem. That assumption is wrong in a way that has real consequences for how you approach this. There are two fundamentally different types of fat in your body, and they behave like completely different tissues. Subcutaneous fat is the kind that sits just beneath the skin. It's the fat you can grab. It's cosmetically noticeable, it responds to diet and exercise over time, and while excess amounts of it aren't ideal, it is metabolically relatively passive. It stores energy, it insulates. It doesn't, on its own, drive the kind of systemic damage that leads to liver disease and cardiovascular risk. Visceral fat is something else entirely. It sits deep inside the abdominal cavity, packed between and around your organs, your liver, your pancreas, your intestines. You cannot see it, you cannot feel it, and you have no direct way of knowing how much of it you're carrying without imaging. What makes visceral fat dangerous isn't just its location, it's its behavior. Visceral fat is metabolically active in a way that subcutaneous fat is not. It releases inflammatory molecules called cytokines directly into the portal circulation, the blood supply that flows straight into the liver. It releases free fatty acids continuously. It disrupts the hormonal signals that regulate appetite and blood sugar. It is, in a very real sense, functioning like a hostile organ that happens to be living inside your abdomen. Research published in The Lancet has been unambiguous on this point for years. Visceral fat is a far stronger predictor of metabolic disease, cardiovascular risk, and liver damage than total body fat or even body mass index. Two people can have the same BMI, the same height-to-weight ratio, and carry dramatically different levels of visceral fat. The person with more visceral fat faces a substantially higher risk of developing fatty liver disease, type 2 diabetes, and cardiovascular events, even if they don't look heavier. This is sometimes described in the research literature as the metabolically obese normal weight phenotype. People whose standard metrics look acceptable, but whose internal fat distribution tells a completely different story. This is why the number on the scale tells an incomplete story. A person can lose 15 pounds of subcutaneous fat, watch the scale move in the right direction, and still carry dangerous levels of visceral fat that haven't budged. Conversely, someone can make targeted changes, the kind we'll get into later in this conversation, and reduce visceral fat significantly without the scale reflecting much of it at all. The fat that moves the needle is the fat you will never find on your own. What drives visceral fat accumulation, and what drives it specifically after 50, is where the mechanism becomes clear. And it starts with something most people think of as a blood sugar problem, when it's actually something much more foundational than that. To understand why the liver accumulates fat, you have to understand what the liver is actually doing every moment of every day. It is the body's central metabolic hub, the organ that processes everything absorbed from the digestive tract, converts nutrients into usable fuel, packages and exports fats, filters toxins, and regulates the slow release of glucose into the bloodstream. It is doing all of this simultaneously, continuously, without rest. And after 50, the environment it operates in becomes significantly more demanding. The process that leads to fat accumulation in the liver has a specific trigger, and that trigger is a sustained excess of energy arriving at the liver faster than it can be processed and exported. When you eat carbohydrates, they are broken down into glucose and absorbed into the portal circulation, that same blood supply that feeds directly into the liver. Under normal metabolic conditions, the liver takes up some of that glucose, the pancreas releases insulin to help muscles absorb the rest, and the system stays in balance. But when insulin signaling begins to weaken, a process called insulin resistance, which we'll come back to in detail, glucose stays elevated in the bloodstream longer. The pancreas compensates by producing more insulin, and chronically elevated insulin sends a very specific signal to the liver: convert this excess energy into fat and store it. That process of converting carbohydrates into fat inside the liver is called de novo lipogenesis. It is a normal metabolic function that becomes pathological when it is running continuously, at high volume, because the upstream signals never quiet down. The liver is not malfunctioning. It is doing exactly what it is being told to do by a hormonal environment that has gone out of balance. The fat that accumulates inside liver cells, the hepatocytes, begins to impair those cells' ability to function normally. Inflammation follows. And if the process continues long enough without intervention, inflammation can progress to scarring, a stage called fibrosis, which is where the damage becomes significantly harder to reverse. After 50, several biological shifts accelerate this process. Muscle mass declines, and muscle is the body's primary glucose disposal site. Less muscle means less capacity to clear glucose from the bloodstream after a meal, which means longer periods of elevated blood sugar and elevated insulin, which means a stronger, more sustained signal to the liver to store fat. Hormonal changes compound this. In women, the loss of estrogen after menopause is associated with increased visceral fat deposition and reduced insulin sensitivity. In men, declining testosterone has a similar effect on body composition and glucose metabolism. The NIDIC has documented that the prevalence of fatty liver disease rises sharply in the decade following menopause in women, a pattern that closely tracks these hormonal changes rather than dietary ones alone. This is the mechanism most people never hear about. They're told to eat less fat, cut calories, exercise more. And when those interventions don't produce the expected results, they assume something is wrong with their effort. What's actually happening is that they're treating a hormonal and metabolic problem with strategies designed for a simpler one. The liver is downstream of a system that needs to be addressed at its source, and that source has a name. Insulin resistance. It's a phrase that gets used frequently enough that most people have heard it, but rarely explained precisely enough that they actually understand what it means, or why it sits at the center of nearly every metabolic problem that becomes common after 50. Here is what's happening. Insulin is a hormone produced by the pancreas whose primary job is to act as a key. It binds to receptors on cells, particularly muscle cells and liver cells, and unlocks the door that allows glucose to enter. When cells are insulin sensitive, this system works efficiently. A small amount of insulin produces a strong response. Blood sugar rises after a meal, insulin is released, glucose is cleared, insulin levels fall back down. The whole cycle completes cleanly. Insulin resistance means the locks have become less responsive to the key. The cells don't react as strongly to insulin signal as they once did. The pancreas detects that blood glucose isn't clearing up properly and does the only thing it can. It produces more insulin. For a while, sometimes for years, this compensation works. Blood sugar stays in a normal range because the pancreas is working harder to keep it there. But insulin itself, chronically elevated, is doing damage in the background. It is driving fat storage in the liver. It is promoting visceral fat accumulation. It is fueling low-grade systemic inflammation. And eventually, if the resistance deepens enough, the pancreas can no longer compensate, and blood sugar begins to rise, which is when type 2 diabetes is diagnosed. But the metabolic damage started long before that diagnosis. What causes insulin resistance to develop? The answer is multifactorial, but the dominant contributors are well established. Excess visceral fat, particularly the fat sitting around the liver and pancreas, releases inflammatory signals and free fatty acids that directly impair insulin signaling at the cellular level. Chronic physical inactivity reduces the density and responsiveness of insulin receptors in muscle tissue. Diets consistently high in refined carbohydrates and added sugars keep insulin elevated for sustained periods, gradually blunting the cellular response. Poor sleep and chronic stress both elevate cortisol, which counteracts insulin's effects. And age itself plays a role. Research from the American Diabetes Association has shown that insulin sensitivity declines measurably across the decades, independent of weight gain, as part of normal aging, a baseline shift that makes everything else harder to manage. The reason insulin resistance is the denominator of this conversation is that it connects everything. The fat in the liver, the fat in the abdomen, the inflammation, the cardiovascular risk, and the difficulty losing weight despite genuine effort. When someone with significant visceral fat and hepatic steatosis tries to reduce calories and exercise more but sees limited results, it is often because insulin remains chronically elevated, keeping the body in a fat storage state regardless of caloric intent. The body is not ignoring the effort. It is locked in a hormonal pattern that effort alone cannot override. What insulin resistance does to the liver is one part of the story. What it does to the organs beyond the liver is where the stakes become considerably higher. Fatty liver disease is named after the liver, but it rarely stays there. That's the part of this that most people, and frankly, many physicians outside of hepatology, don't fully appreciate. The liver is where the damage is most visible on imaging, but it is not the only organ being affected by the metabolic environment that created it. Start with the heart. The connection between fatty liver disease and cardiovascular risk is one of the most well-documented relationships in metabolic medicine, and it runs deeper than shared risk factors. The inflammatory cytokines released by visceral fat and by a fat-infiltrated liver enter the systemic circulation and promote the kind of low-grade chronic arterial inflammation that drives atherosclerosis, the progressive narrowing of arteries by plaque. The liver itself, when impaired by fat accumulation, produces higher levels of VLDL particles, a type of cholesterol carrier that contributes to plaque formation. It also produces more fibrinogen, a clotting protein that increases the risk of thrombotic events. The European Heart Journal has published data showing that individuals with MALD have a significantly elevated risk of major cardiovascular events, independent of traditional risk factors like hypertension and smoking, meaning the liver condition is itself contributing to cardiovascular risk, not merely coexisting with it. The kidneys are next. Chronic kidney disease and fatty liver disease share a bidirectional relationship that is increasingly recognized in nephrology research. The same insulin resistance and inflammatory load that damages the liver gradually impairs the filtration capacity of the kidneys. People with MASLD have a measurably higher rate of declining kidney function over time, and the mechanism is not simply shared lifestyle factors. It appears to involve direct inflammatory signaling from the dysfunctional liver tissue to the renal system. The brain is perhaps the most sobering part of this picture. Visceral fat and the metabolic dysfunction associated with it have been linked to accelerated cognitive decline in multiple large longitudinal studies. The National Institute on Aging has supported research showing that insulin resistance in the brain, sometimes described as type 3 diabetes in the scientific literature, though that term remains contested, impairs the brain's ability to use glucose as fuel, which contributes to neuronal dysfunction over time. Visceral fat in midlife, specifically, has been identified as a risk factor for dementia in later life, with the inflammatory burden appearing to be a key mediating pathway. None of this means that a diagnosis of fatty liver disease is a sentence for cardiovascular collapse or cognitive decline. It means that the metabolic environment producing the liver condition is simultaneously stressing multiple organ systems, and that addressing it has benefits that extend far beyond what shows up on a liver ultrasound. The case for taking this seriously is not about the liver in isolation. It is about what the liver's condition reveals about the state of the entire system. There is one driver of that system that rarely appears in conversations about fatty liver, and it may be the most underestimated variable in the entire equation. Ask someone what causes fatty liver disease, and they will almost certainly talk about food. What they eat, how much they eat, how often they eat. And food matters. We'll get into the specifics of that in detail. But there is a category of driver that operates entirely outside the kitchen, and it has a measurable, documented effect on liver fat, visceral fat accumulation, and insulin resistance. That driver is the chronic activation of your body's stress response system. When you encounter a threat, physical, psychological, or emotional, your body releases cortisol. This is the primary stress hormone produced by the adrenal glands, and its job in an acute situation is to mobilize energy fast. It raises blood sugar by triggering glucose release from the liver. It suppresses non-essential functions. It sharpens focus and prepares the body for immediate physical response. In short bursts, cortisol is adaptive and necessary. The problem is what happens when it is no longer short. Chronic stress, the kind that comes not from a single threat but from sustained financial pressure, caregiving demands, social isolation, or simply the accumulated weight of a life with too many obligations and too little recovery, keeps cortisol elevated at low but continuous levels. And chronically elevated cortisol does something very specific to fat distribution. It preferentially drives fat storage in the visceral compartment, the abdomen, the area around the liver. Research has consistently shown that people with higher cortisol output carry significantly more visceral fat independent of their total caloric intake. The stress is not just making you eat more. It is directing where the fat goes even when you are not eating more. Cortisol also directly antagonizes insulin. It raises blood glucose, which requires more insulin to manage, which deepens the insulin resistance cycle described earlier. This is why people under sustained chronic stress can maintain a reasonable diet, exercise consistently, and still find that visceral fat and liver fat are resistant to change. The hormonal environment is working against them in a way that willpower and meal planning cannot fully address. Sleep is the other half of this. The two are deeply connected. Chronic stress degrades sleep quality, and poor sleep independently elevates cortisol the following day, creating a feedback loop that is difficult to interrupt without addressing both simultaneously. The American Academy of Sleep Medicine has established that adults require 7 to 9 hours of quality sleep for normal metabolic function. Research tracking metabolic changes in healthy adults found that just 2 weeks of sleeping 6 hours per night produced measurable increases in liver fat, even with caloric intake held constant. Deep sleep is also when the pituitary gland releases growth hormone, which plays a critical role in fat metabolism and muscle preservation. Disrupted sleep suppresses this release, and for someone over 50, where growth hormone levels are already declining with age, poor sleep amplifies that deficit in a way that directly affects body composition. This is not a peripheral issue. Sleep and stress sit upstream of nearly every intervention that works for fatty liver and visceral fat. Addressing the diet without addressing these is like trying to bail out a boat without looking for the hole. The dietary conversation around fatty liver is one of the most cluttered spaces in popular health media. Low fat, low carb, intermittent fasting, Mediterranean, carnivore. The volume of competing claim makes it genuinely difficult to know what the evidence actually supports, and what is simply the loudest voice in the room at any given moment. So let's go to what the research shows and distinguish between what works in principle and what works specifically for someone over 50, dealing with insulin resistance and hepatic fat accumulation. The first and most important clarification: dietary fat is not the primary driver of fatty liver disease. This is counterintuitive given the name, but the science has been consistent on this point for years. The fat that accumulates in the liver comes predominantly from two sources: de novo lipogenesis, the process of converting excess carbohydrates into fat inside the liver itself, and the overflow of free fatty acids from visceral adipose tissue. Dietary fat, particularly in the context of a diet that is not already generating a massive carbohydrate surplus, is a relatively minor contributor. Cutting fat from the diet without addressing refined carbohydrate intake typically produces little to no improvement in hepatic fat levels. What does move the needle? The evidence most consistently points to reducing refined carbohydrates and added sugars, specifically fructose. Fructose is metabolized almost exclusively by the liver, unlike glucose, which is distributed across multiple tissues. When it arrives at the liver in large quantities, as it does with regular consumption of sugar-sweetened beverages and processed foods with added high fructose corn syrup, it drives de novo lipogenesis directly and potently. A study published in the Journal of Hepatology demonstrated that replacing fructose with other carbohydrates without changing total calories produced significant reductions in liver fat within 8 weeks. The problem is not simply how much you eat. It is what specific inputs are driving the liver's fat production machinery. Beyond fructose, overall carbohydrate quality matters substantially. Diets that reduce the glycemic load, prioritizing carbohydrates that digest slowly and produce gradual rather than sharp rises in blood sugar, reduce insulin demand throughout the day, which over time improves insulin sensitivity and reduces sustained lipogenic signaling to the liver. This is the mechanism behind why both Mediterranean-style eating patterns and lower carbohydrate approaches show benefit for fatty liver in clinical trials. Different dietary philosophies, same metabolic lever, lower and more stable insulin levels. Protein deserves specific attention for people over 50. Adequate intake, generally in the range of 1.2 to 1.6 grams per kilogram of body weight per day, supports muscle preservation during weight loss, which matters because muscle mass is the primary determinant of insulin sensitivity. Losing weight while losing muscle is a common failure mode in people who reduce calories without attention to protein. The scale moves. The metabolic problem persists. One consistent finding across dietary intervention studies is that 5 to 10% of body weight loss produces clinically meaningful decreases in hepatic fat. But the composition of that weight loss and the speed at which it occurs shapes whether the improvement is durable. And that second part connects to something almost universally overlooked in conversations about reversing this condition. Exercise is consistently listed as a treatment for fatty liver disease, and the recommendation is accurate. But the way it is usually framed as a calorie-burning tool, a way to create an energy deficit that forces the body to draw down its fat stores, misses the more important mechanism entirely. The reason exercise works for hepatic fat and visceral fat is not primarily about calories. It is about what happens to insulin sensitivity, glucose disposal, and liver fat oxidation when muscles are regularly challenged to work. Here is the more precise picture. Skeletal muscle is the body's largest insulin-sensitive tissue. When muscle contracts during exercise, it activates a cellular pathway, mediated by a protein called GUT4, that allows glucose to enter muscle cells independent of insulin. This means that during and immediately after exercise, the body can clear glucose from the bloodstream without requiring elevated insulin levels. Over time, with regular training, the density and responsiveness of insulin receptors in muscle tissue increases, and the baseline insulin demand throughout the day decreases. That reduction in chronic insulin exposure is one of the most powerful levers available for reducing hepatic fat accumulation, and it operates regardless of whether the exercise session produces meaningful caloric expenditure. The research on exercise type is nuanced and worth understanding. Aerobic exercise, sustained moderate intensity activity like brisk walking, cycling, or swimming, has the strongest evidence base for direct reduction of liver fat. A meta-analysis published in the Journal of Hepatology found that aerobic training reduced hepatic fat content significantly even in the absence of weight loss, which is a crucial finding. It means the liver is responding to the metabolic signal of movement itself, not just to the downstream effects of losing body weight. In practical terms, 150 minutes of moderate aerobic activity per week, the threshold established by major health guidelines, produces measurable improvements in liver fat over a period of weeks to months. Resistance training adds a different, but equally important dimension. Building and preserving muscle mass increases the body's overall glucose disposal capacity around the clock, not just during exercise sessions. For someone over 50 where sarcopenia, the age-related loss of muscle tissue, is already underway, resistance training is not optional. It is the primary defense against the progressive decline in insulin sensitivity that comes with muscle loss. The combination of aerobic and resistance training produces larger reductions in visceral fat than either modality alone, according to data published in obesity reviews, and the effect is particularly pronounced in adults over 50. One practical point research supports but rarely gets communicated clearly: the timing and distribution of movement across the day matters as much as the formal exercise session. Prolonged sitting, even in someone who exercises regularly, is independently associated with higher visceral fat and worse metabolic markers. Breaking up sedentary time with short bouts of walking or light movement every hour reduces postprandial glucose spikes, lowers average daily insulin levels, and over time contributes meaningfully to visceral fat reduction. The formal workout and the accumulated movement of the day are not interchangeable, but they are both contributing to the same metabolic outcome. The body, in other words, is always listening. What it hears between the workouts matters almost as much as what happens during them. Walk into any health food store or scroll through any wellness-focused corner of the internet, and you will find no shortage of products claiming to cleanse, support, or detoxify the liver. The language is confident, the packaging is convincing. The evidence behind most of it is either thin, misrepresented, or non-existent. So this is worth handling carefully, because there are compounds with genuine, peer-reviewed support for hepatic fat reduction, and they exist alongside a much larger category of products trading on the liver's cultural moment without earning the claim. Start with the compound that has the most consistent evidence: vitamin E. In people with MASLD who do not have diabetes, high-dose vitamin E, 800 international units per day, has been shown in randomized controlled trials, including the PIVENS trial funded by the NIH, to produce significant reductions in liver inflammation and hepatic fat content. The effect is real, and the evidence is credible. The caveat is equally real. High-dose vitamin E supplementation carries risks at extended durations and is not appropriate for everyone. This is a conversation to have with a physician, not a supplement to self-prescribe. Omega-3 fatty acids, primarily EPA and DHA from fish oil, have a well-established effect on triglyceride reduction and a more modest but documented effect on hepatic fat. The American Association for the Study of Liver Diseases has noted that omega-3 supplementation shows benefit for liver fat in multiple trials, though the magnitude of effect is smaller than dietary and exercise interventions. The mechanism involves both reduced de novo lipogenesis and improved fat export from the liver. Coffee is perhaps the most unexpected entry in this category, and also one of the most robustly supported. Multiple large epidemiological studies have found an inverse relationship between regular coffee consumption and the severity of fatty liver disease. The mechanism appears to involve polyphenols, particularly chlorogenic acids, that reduce hepatic fat accumulation and have antifibrotic effects on liver tissue. This association holds for both caffeinated and decaffeinated coffee. 3 to 4 cups per day represents the range where benefit is most consistently observed. What about milk thistle and the long list of herbal liver supplements? The honest answer is that the evidence is weak and largely derived from small studies with significant methodological limitations. Silymarin, the active compound in milk thistle, has shown some anti-inflammatory properties in cell studies, but no large randomized controlled trial has established meaningful clinical benefit for fatty liver disease in humans. That does not make these compounds harmful. It makes them unproven. The distinction matters when someone is choosing where to invest their effort and their money. The interventions with the strongest evidence are also the least profitable to sell. The supplements with the loudest marketing have the thinnest science. That asymmetry is not accidental. There is a pattern that plays out repeatedly in people who decide to take fatty liver seriously. They read enough to understand that weight loss matters, they commit to the process with genuine discipline, and they lose weight, sometimes a significant amount, and quickly. The liver enzymes improve, the doctor is encouraged. And then, somewhere in the months that follow, the progress stalls, the markers drift back in the wrong direction, and the person is left wondering what went wrong when everything seemed to be working. What went wrong in most of these cases is the speed. Rapid weight loss, generally defined as more than 1 to 1.5 pounds per week sustained over several weeks, triggers a specific metabolic response that works against liver health even as the scale moves in the right direction. When the body loses weight faster than it can safely mobilize fat from peripheral stores, it begins breaking down muscle tissue as an additional fuel source. That muscle loss reduces insulin sensitivity, which undermines the very metabolic improvement the weight loss was supposed to produce. At the same time, the rapid mobilization of fat from adipose tissue floods the portal circulation with free fatty acids, the same pathway through which visceral fat delivers its inflammatory load to the liver. The liver, compromised, is now receiving a surge of fatty acids it cannot process efficiently, and fat infiltration can paradoxically worsen during periods of aggressive caloric restriction. Very low-calorie diets, below 800 calories per day, have an additional risk specific to the liver. They significantly increase the risk of gallstone formation. Rapid weight loss changes the composition of bile, increasing its cholesterol concentration and reducing the contractile activity of the gallbladder, which creates conditions for crystal formation. The NIDIC notes that people who lose more than 3 pounds per week face a substantially elevated risk of developing gallstones, a complication that can require surgical intervention and that adds a significant burden on top of the underlying liver condition. The more durable and metabolically beneficial approach is a moderate caloric deficit, typically 500 to 750 calories below maintenance, that produces gradual weight loss while preserving muscle mass. This is slower, it requires more patience, and it produces better outcomes, not just on the scale but in the biological markers that actually reflect what is happening inside the liver and around the visceral fat deposits. Research consistently shows that gradual weight loss is associated with greater reductions in liver fat as a proportion of total weight lost, more durable improvements in insulin sensitivity, and lower rates of weight regain, which is critical because weight regain after rapid loss is associated with accelerated return of visceral fat. often at higher levels than before. The framing that serves people best here is not weight loss as the goal, but metabolic restoration as the goal, with weight loss as one of the indicators that the process is working. That reframe changes the timeline, the strategy, and, perhaps most importantly, the relationship with the scale when it doesn't move as fast as expected. How you know the process is working when the scale is an unreliable narrator brings us to the last piece of this conversation, and it lives in the numbers your doctor can actually measure. Most people who have been told they have fatty liver disease received that information from an ultrasound, a routine abdominal scan that flagged increased echogenicity in the liver, the technical way of saying the tissue looks brighter than it should because fat is present. Ultrasound is a reasonable screening tool, but it has significant limitations. It cannot reliably detect fat infiltration below roughly 20 to 30% of liver volume, which means meaningful improvement can occur without any visible change on imaging. A follow-up ultrasound that looks similar to the first one does not mean nothing has changed. It may mean the changes are happening below the threshold the tool can see. The markers that track metabolic improvement more sensitively live in routine blood work. ALT and AST, the liver enzymes, are the most commonly monitored, and falling levels over time signal that hepatic inflammation is reducing. But they are lagging indicators, and they can be normal even with significant fat present. The more informative panel includes fasting insulin and fasting glucose, from which a calculation called HOMA-IR can be derived, a numerical index of insulin resistance that tracks the underlying metabolic driver more directly than liver enzymes alone. Triglycerides are another sensitive marker. They fall relatively quickly in response to reduced refined carbohydrate intake and improved insulin sensitivity, often within weeks, making them one of the earliest objective signals that dietary changes are having the intended metabolic effect. Waist circumference is underused as a monitoring tool. Because visceral fat sits in the abdominal cavity, waist measurement tracks its reduction more directly than body weight does. A reduction of 2 to 4 centimeters over 3 to 6 months, even without dramatic scale movement, is a clinically meaningful signal that visceral fat is responding. The measurement should be taken consistently, same time of day, same anatomical landmark, relaxed exhalation, to be interpretable over time. For those who want more precise quantification, MRI-PDAF, proton density fat fraction, is the current gold standard for non-invasive assessment of hepatic fat content. It can detect changes of as little as 1 to 2% in liver fat, making it far more sensitive than ultrasound for monitoring treatment response. The practical implication is that monitoring progress requires a panel of indicators, not a single number. The scale, the enzymes, the triglycerides, the waist, the fasting insulin, each one tells part of the story. Building the habit of tracking several of them together and bringing that data to a physician who understands what to look for is what separates people who are genuinely reversing this condition from people who are simply hoping they are. Subscribe and keep this video somewhere you can find it again. If someone in your life is carrying any of this without knowing it, send it to them today, because there is one part of this we have not covered yet. What actually happens inside the liver when the process reverses, and it reframes the weight of everything that came before. The liver is one of the few organs in the human body capable of genuine regeneration. Not compensation, not adaptation, actual structural regeneration. Liver cells that have been damaged by fat infiltration and inflammation can, under the right conditions, be replaced by healthy functioning tissue. This is not a metaphor for feeling better. It is a biological process that shows up on imaging, in blood work, and in the downstream organ systems that were being stressed by the dysfunctional liver environment. Understanding what that reversal actually looks like and what drives it at the cellular level changes how you think about every intervention discussed in this conversation. When hepatic fat content begins to fall, the first thing that changes is not the enzymes and not the imaging. It is the inflammatory signaling. The liver cells that were swollen with fat were producing cytokines, those inflammatory molecules that were entering the systemic circulation and stressing the cardiovascular system, the kidneys, the brain. As fat is cleared from the hepatocytes, that inflammatory output decreases. This happens before the ultrasound changes, before the ALT normalizes, before any visible marker shifts. The body is quieting a fire that had been burning at low intensity for years, and the first evidence of that is systemic. People often report improved energy, reduced joint discomfort, and better cognitive clarity in the early months of a genuine metabolic intervention, before any clinician would call the liver recovered. The next stage is hepatocyte restoration. As the fat clears and the inflammatory load decreases, the liver's resident immune cells, Kupffer cells, shift from a pro-inflammatory activation state toward a reparative one. Stellate cells, which produce the collagen that causes fibrosis when chronically activated, begin to deactivate. In early-stage disease, simple steatosis without significant fibrosis, this process can result in complete histological normalization, meaning a liver biopsy would show tissue indistinguishable from a healthy liver. Even in cases where early fibrosis is present, regression of fibrosis has been documented in multiple clinical trials following sustained lifestyle intervention, a finding that was considered unlikely just 2 decades ago. What this means practically is that the timeline of recovery is measured in months to years, not weeks. And the interventions that produce the most durable reversal are the ones that address the metabolic environment rather than the liver symptom. Reducing visceral fat, improving insulin sensitivity, lowering chronic cortisol load, sleeping adequately, moving consistently. These are not supporting actors in a treatment plan centered on the liver. They are the treatment. The liver responds to the environment you create around it. There is a moment that patients describe, sometimes around the 6-month mark of a sustained and honest effort, where the blood work comes back and something has genuinely shifted. The triglycerides are down, the fasting insulin is lower, the waist measurement has moved, and the person realizes, perhaps for the first time, that the body they are living in is capable of change in a direction they had stopped believing was available to them. That moment is not the finish line. It is the confirmation that the process is real, that the biology is responding, and that the work is worth continuing. If this conversation gave you something useful, share it with 5 people who could use it, and leave a comment telling us what topic you want to go deeper on next. Until next time, take care of yourself.